Hello, my name is Nathalia Bosoko, and I am pleased to be a part of this conference. I am a current graduate member of the British Psychological Society. I graduated in psychology at Kington University of London, as well as completed a master's degree in clinical psychology at Royal Holloway University of London, where I additionally completed my research, which I'm going to talk about today. The title of this presentation is the contribution of perceived memory and information processing deficits on multiple sclerosis cognitive difficulties. I am going to introduce you to this topic by underlying its importance, as multiple sclerosis is one of the major causes of disability in young adults within Western countries. More than a half of people with MS develop a cognitive impairment, being this considered a major quality of life determinant. For instance, information processing speed and memory difficulties are the most common cognitive symptoms experienced in people with this condition. Despite the rise in research underlying this subject and the development of cognitive batteries over the past few decades, such as the Multiple Sclerosis Neuropsychological Questionnaire, which is a valid self-report measure of global cognitive difficulties for people with MS, or the Attentional Functional Index and the Prospective and Retrospective Memory Questionnaire, which are also self-report measures for perceived cognitive functioning, assessing perceived effectiveness in common activities which require attention and memory. However, cognitive impairment remains often overlooked. It is also little known about MS variability between cognitive patterns isolated and co-occurring cognitive deficits. At the end of this presentation, you will have a deeper understanding of the nature of the relationship between perceived cognitive function and its effect on global MS cognition, with the aim of finding or develop a tailored questionnaire that a person with MS could fill in, providing more information about personal experience and more insights on the mechanisms underlying independent and global perceived cognitive dysfunction in MS. We need to understand first the definition of multiple sclerosis. Multiple sclerosis is a chronic common autoimmune condition or disease that affects any region of the central nervous system. The central nervous system consists of the brain and the spinal cord. Multiple sclerosis causes a wide range of symptoms, which take place when a person's immune system attacks the myelin of the neurons. The myelin is a fatty substance that coats the neuron's axon to protect the nerve fiber. These attacks cause inflammation, neurodegeneration, and tissue damage, which disrupts the neural signals produced by the nerve's impulse. This may obstruct the communication between the brain and the rest of the organism. As a result of these individual central nervous system lesions, people with MS suffer from several symptoms, being neurological, cognitive, physical, physiological, psychological, and neuropsychological. Some examples are lack of balance, loss of sensation, bladder dysfunction, difficulty in walking, fatigue, numbness, blurred or double vision, sexual problems, tingling, or spasticity, among others. Multiple sclerosis has a typical early onset of 20 to 40 years of age and affects more females than males according to the statistics, although the gender bias remains uncertain. And you may wonder what causes MS. Well, the roots of MS remain mysterious, but doctors and other professionals see some surprising trends. According to studies, risk factors appear to be associated with both genetic and environmental components. For example, prevalence and migration studies suggested that the prevalence of the disease increases with higher latitudes and varies between ethnicity and race, being the Caucasian European group at higher risk. Research has also suggested further environmental and genetic factors, such as smoking exposure, certain vitamins deficiency, like vitamin D, obesity, decrease in UV radiation exposure, and both MHC and non-MHC genes, being the human leukocyte antigen considered the strongest genetic risk factor in MS genetic onset at the moment. Multiple sclerosis may have different clinical presentations, and these vary according to the area of the central nervous system affected by the attacks or relapses, and the organism's ability to recover from them, also referred to as remissions. Therefore, MS may present in different forms. The first form, known as clinically isolated syndrome, is characterized by the appearance of a first or several isolated episodes of typical MS neurological symptoms caused by inflammation and demyelination in the central nervous system, but without the disease's manifestation. These symptoms may increase the risk of developing MS, but early treatment might delay the onset. Also, current neuroimaging advances have contributed to the improvement of MS diagnosis and evaluation. This gave rise to the concept of radiologically isolated syndrome. This is also an early MS risk indicator, where abnormal brain activity is detected on MRI without an outwarding symptomatology of the disease. Other clinical presentations include relapse and remitting. This is characterized by unpredictable relapses from time to time, followed by a period of full or partial recovery. The duration of the symptoms might range from days or weeks to years. Another one, primary progressive, is characterized by a gradual degeneration followed by mild or any recovery at all. Individuals diagnosed with this type of MS might sometimes experience relapses on top of the progression. In this case, this form is known as progressive relapsing multiple sclerosis. Finally, secondary progressive multiple sclerosis is a transitional presentation that normally occurs 10 to 20 years after relapse and remitting. It is very similar to primary progressive. After a relapse, people who do not fully recover are prone to move to this stage. The diagnosis of this condition is normally and generally suggested by the manifestation of the symptoms of the patients, but it is accurately concluded by means of several neurological assessments, as well as by different medical examinations like blood tests, radiological and laboratory investigations that includes brain and spinal magnetic resonance imaging, means MRI, cerebrospinal fluid analysis, and visual evoked potentials. Just as the cause of this disease still remains undetermined, nowadays researchers have not found a cure for MS yet. However, there is a great range of treatments available to help MS patients cope with, manage, and reduce the symptoms and relapses. These treatments include pharmacological and non-pharmacological interventions and lifestyle changes, along with mental and well-being therapy. Some examples of these MS interventions and treatments are disease-modifying drugs, steroids, deep brain stimulation, occupational therapy, neurorehabilitation, whole-body cryostimulation, physical therapy and exercise, or alternative therapies and medicine, such as yoga, acupuncture, relaxation and meditation, herbal remedies, massage, and diet or dietary supplements. Now, having a general understanding of MS, let's move back onto our main focus, cognition. As previously mentioned, research has shown that more than a half of all people with MS might develop difficulties with cognition, which may also interact with and enhance the neuropsychiatric and physical symptoms of the condition, for example, by increasing fatigue or affecting mood and overall motivation. Cognition refers to a broad range of high-level brain processes and functions. These functions may include the ability to learn and remember information, to plan and organize tasks, to solve different problems or challenges, or to focus. It is known that processing speed has a main influence on other types of cognitive processes. However, cognitive dysfunction occurs when all these abilities are negatively affected or difficult to perform due to changes in processing speed. When a person reports a cognitive problem, he or she describes a change in function from a previous level, what it means, a cognitive decline. For people with MS, certain cognitive functions are more likely to be affected than others. Generally, these changes in cognitive function are mild and may involve one or two areas. However, in fewer people with MS, these changes are more challenging. These functions might be classified as information processing, memory, attention and concentration, executive functions, visuospatial functions, and verbal fluency. Cognitive impairment in MS may reduce life satisfaction and health-related quality of life of patients. Also, it may be considered the most important determinant of employment status and associated societal cost of people with the disease. Additionally, other activities and characteristics such as driving safety, household tasks completion, social activity, physical independence, rehabilitation progress, coping, and treatment adherence are usually highly affected too. The most common deficit in multiple sclerosis corresponds to information processing speed. Information processing is the core concept of cognitive psychology, which sees individuals as information processors in a similar way to computers. That is to say, as machines that collect information and follow a program to reproduce such information. The information processing speed approach is based on a number of basic assumptions, which include the idea that information present in the environment is processed and transformed systematically through several systems, for example through attention, perception, and through memory. Speaking about memory, long-term memory is one of the principal cognitive functions affected by MS as well. The long-term memory deficits, have often been associated to retrieval failure. Some researchers often use alternative classifications to refer to long-term memory based on the temporal direction of the memories. For example, retrospective memory, which refers to the process of recalling past memories or episodes, for example, people, words, or events. It includes semantic, episodic, and autobiographical memory, as well as declarative memory. Another example is prospective memory. Prospective memory is employed when the content is to be intentionally remembered in the near future. This means remembering to remember. Prospective memory is often triggered by a cue, and it may be either event-based, when the action is reminded by a specific event, or time-based, when the action or event is planned on a specific time. There is considerable evidence that cognitive impairment in MS extends to activities requiring prospective memory, and that MS is associated as well with impaired retrospective memory. However, increased self-reported memory impairments were significantly correlated with higher levels of normative dissociation experience. as well as with several psychiatric symptoms such as depression, anxiety, and neuroticism rather than neuropsychological variables in people with MS. Magnetic resonance imaging, or MRI, plays an essential role in MS diagnosis and disease surveillance. Therefore, the field of MS is nowadays at the top of novel and innovative MRI technology. This novel technology provides multiple tools for investigating MS-related cognitive deficits. According to early research, cognitive deficits in MS were linked to greater lesion load, and neuroanatomical correlates of cognitive deficits in MS have been found as well, for example in the thalamus. For instance, a study showed the importance of white and gray matter lesions, these lesions' location, microstructural injury, and structural brain damage, including cortical and subcortical, as well as brain atrophy, and discrepant patterns of cerebral activation with fMRI, or functional MRI. These could be useful tools for predicting disease-related cognitive deficits, but also important for gaining knowledge of precise neural bases in order to identify therapeutic targets and treatments. However, whether such correlates directly underlie deficits or are reliable representative of overall or other cerebral damage which mediate links to cognition remains unclear. Advances in ultra-high field MRI, myelin and molecular imaging, including imaging of demyelination and remyelination, and non-conventional MRI techniques are used to examine microstructural cerebral changes, and this would provide more ways to investigate cognitive deficits due to MS. The most promising neuroimaging methods to date includes diffusion tensor imaging, which is a type of MRI technique that enables the measurement of water diffusion rates between cells to produce a microstructural map of the brain. This technique was found to provide supplementary disability progression information over 4 years in MS. Cognitive function is measured using different cognitive assessment tools. There are several cognitive batteries or tests specifically developed for MS. These include tests of processing speed, memory, and other functions individually administered by trained professionals. For example, information processing speed is typically assessed as the amount of work performed within a time frame, whereas episodic memory is assessed as the amount of information learned and recalled, for example, words or visual stimuli, using several tests. These tests were developed by a panel or committee of experts, which reviewed and discussed the relevant literature on MS-related cognitive dysfunction, as well as they considered psychometric factors relevant to neuropsychological assessment. As a result, for example, they created the minimal assessment of cognitive function in MS. This test is a 90-minute battery composed of 7 neuropsychological tests that covers the 5 most common cognitive impairments in MS, which include processing speed and working memory, as well as learning and memory, executive function, visual spatial processing, and word retrieval. Further measures for assessing other factors that may potentially confound interpretation of neuropsychological data are also widely and commonly employed as strategies for improving future neuropsychological assessment of people with MS, such as the symbol-digit modalities test, the brief visual spatial memory test revised, and the selective reminding test or California verbal learning test 2, which are the most sensitive tests for cognitive monitoring in MS nowadays. However, these tests are not exempt of limitations. For example, patients referred for specific clinical or research questions beyond monitoring often require more comprehensive evaluations. Also, despite of the briefness of MS batteries based on neuropsychological standards, most of them require even 15 minutes of one-on-one testing for every patient. which might not be very practical in terms of MS care standards. Series of possible alternatives has been proposed, such as the usage of computerized tests. Online testing could be the main key of innovation that would improve most important areas of neuropsychological monitoring in MS cognition. This includes better detection of cognitive decline, large datasets from representative samples to advance understanding of prevalence, time course and risk factors for decline, and greater feasibility of post-market studies of disease-modifying therapy effects on cognition. A self-report study is a type of method in which participants or respondents are able to answer questionnaires, surveys, or polls without interference. Researchers obtain participants' views or opinions about their own attitudes, feelings, beliefs through this method. A number of studies have indicated that people with brain damage are prone to underestimate neuropsychological impairment when self-report ratings are compared to informant ratings. But these discrepancies have not been well examined in people with MS. Moreover, evidence also showed a greater underestimate or less self-awareness of cognitive dysfunction and unemployment within people with MS. Perceived cognitive impairment might be considered as the major health-related quality of life and work outcomes determinant, and this could be related to this fact. Self-reported cognitive measures may be an indicative for objective cognitive impairment in MS population, but it's difficult to assess the perceived cognitive impairment accurately due to the variability in how it is defined. As we're talking about information processing speed and memory, let's talk about two self-report tools for this. The Attentional Functional Index is a 13-item self-report measure with 3 subscales designed to assess cognitive function and perceived effectiveness or performance on tasks requiring attention and working memory, particularly the ability to formulate plans, carry out tasks, and function effectively in daily life. Its construct gained validation using exploratory principal component factor analysis with Varimax rotation on a breast cancer study and has demonstrated usefulness for assessment of perceived cognitive function. This tool could be used to assess information processing. On the other hand, the Prospective and Retrospective Memory Questionnaire is a valid 16-item self-report questionnaire assessing prospective and retrospective memory impairment on a 5-point scale. Participants are asked to indicate their perceived memory errors frequency. This is a useful tool for assessing memory. As previously mentioned, the need for cost-effective screening techniques that identifies neuropsychological impairment in people with MS, as well as the requirement of cognitive testing with subsequent interpretation of existing methods by a neuropsychologist, led to the development of a brief self-report that was elaborated by pooling 80 items based on literature review and consultation with healthcare professionals. The set was reduced to 15 items through analytical methods. As a result, the Multiple Sclerosis Neuropsychological Screening Questionnaire, or MSNQ, emerged, which is a valid self-report measure of global cognitive difficulties for people with MS. People with MS are often characterized by studies as cognitively impaired based on overall performance across multiple tests that measure several or specific cognitive functions. However, this could lead to heterogeneity of impaired groups of patients with different isolated or co-occurring cognitive deficits. This may change the interpretation of results and confront comparisons across studies, specifically thus aiming to identify neural correlates of cognitive impairment. Moreover, cognitive impairment might differ across specific cognitive domains. Therefore, research should better characterize groups as impaired in isolated or combined. Research should also utilize purer measures for each cognitive domain. This study was carried online and included a total number of 76 adult male and female participants with MS from the United Kingdom. We analyzed how information processing and prospective and retrospective memory deficits contribute to self-report of cognitive difficulties on the Multiple Sclerosis Neuropsychological Questionnaire and the nature of this relationship. All participants completed a series of multiple sclerosis demographic cognition questionnaires along with the Multiple Sclerosis Neuropsychological Questionnaire, which was the dependent variable, and the Attentional Functional Index and Prospective and Retrospective Memory Questionnaires as independent variables. Then we performed a within subjects correlation and a multiple regression analysis to test the hypothesis that perceived attention or information processing speed and memory deficits are associated with the Multiple Sclerosis Neuropsychological Questionnaire. This analysis also explained the nature and the power of this relationship. Correlational analyses were executed to test the statistical relationship between the three variables. The results of the analysis were statistically significant, indicating a strong positive correlation. This suggests that self-reported prospective and retrospective memory and information processing speed are significantly associated with self-reported cognitive deficits on the Multiple Sclerosis Neuropsychological Questionnaire. However, interim analyses were required to examine a possible interaction between all the correlated predictors. Therefore, an additional within subjects multiple linear regression was performed in order to examine the nature of this relationship. A significant regression equation was found, indicating a good model. This suggests that both the prospective and retrospective memory questionnaire and the attentional and functional index are good predictors of multiple sclerosis neuropsychological questionnaire scores in multiple sclerosis population. Being the prospective and retrospective memory questionnaire highly significant. Collinearity diagnostic suggested that there was no multicollinearity between the variables, means no interaction. Therefore, it was concluded that each independent predictor made separate contribution in the statistical relationship with a 73% of variance of the MSNQ, means the multiple sclerosis neuropsychological questionnaire explained by both the prospective retrospective memory questionnaire and the attentional functional index. However, the 27% of variability remaining was unexplained, which could be due to the influence of other factors or confounding variables such as age, gender, or further cognitive features. We found these results amazing because, as predicted, this study showed a strong positive relationship between all the variables, and this supports the usefulness and effectiveness of the prospective and retrospective memory questionnaire and the attentional functional index to measure and assess self-report cognitive function in people with MS. But we found surprising that the statistical analysis showed that both variables made an individual contribution to the predicted outcome, means the multiple sclerosis neuropsychological questionnaire, being perceived memory impairment the main predictor, with greater variability explained. This indicates higher correlation, hence a stronger relationship between the prospective and retrospective memory questionnaire and the multiple sclerosis neuropsychological questionnaire, and that rejects our null hypothesis, despite previous evidence suggesting that information processing speed underlies all cognitive deficits in MS. Thus, these results draw attention to memory. Also, the results indicated that self-report of cognitive difficulties in prospective and retrospective memory, as well as information processing speed, made independent contributions to self-report of perceived global cognitive difficulties on the multiple sclerosis neuropsychological questionnaire. This suggests that different cognitive deficits function and they operate independently rather than through interaction. Some limitations to mention about this study are, for example, the validity and reliability weaknesses that could be due to the lack of control over several confounders, such as respondents' fitness and physical ability to complete surveys and questionnaires, which may be in turn related to the type of MS, and this may result in, for example, a second party completing them on behalf, or in exaggeration or the underreport of the severity of the symptoms. Another limitation could be the mental or psychological state of the respondent. For example, if the respondent suffers from depression or anxiety, these conditions may influence or affect cognitive ability and act as mediators, meaning that they can be directly related to or responsible for cognitive function decline perception rather than the disease, means MS itself. Other confounding variables or limitations are age, education, gender, marital status, or occupation, which is none that they play a role in self-report or perception. This small sample size resulting from the exclusion of missing cases could be considered an additional limitation for this study. These missing cases could be the result of various factors, such as the duration of the physical or cognitive ability of the respondents, as mentioned before. Finally, another limitation is the reliability of the measures employed. The constructs employed in this study have not been yet used or currently tested and validated for the specific assessment of MS cognitive difficulties. Finally, to sum up, we found that perceived cognitive deficits affect global cognitive impairment in people with MS, despite the individual or demographical features or other factors that may have an influence on cognitive decline in MS. Different neuropsychological difficulties or cognitive deficit domains, such as memory or deficits in information processing speed, independently affect global and perceived cognitive impairment of people with MS. To conclude, these findings are relevant for understanding and interpreting the particular and combined mechanisms underlying cognitive impairment in MS, but may also be beneficial to link up with and support neuroimaging studies. Finally, this may help develop and improve assessment instruments to help identify cognitive difficulties. Additionally, this would aid health professionals present health information and raise feasible and effective daily life and treatment adaptations to help improve people with MS quality of life from both a clinical practice perspective and a patient-level experience. Thank you for watching and for your attention. I hope you enjoyed this presentation.